You're at the cutting edge of cardiovascular sciences. I'm your host, John Cook. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist Hospital, and we have a very special guest for you today. First, my apologies for the late start, but we're going to make it up to you with just a wonderful presentation. Dr. Lee Lai is going to introduce our guest.
So good morning, everyone. So today is my great pleasure to introduce our special guest, Dr. Joseph Hill. Dr. Joseph Hill is a professor of internal medicine and molecular biology, James T. Willison, MD, Distinguished Chair in Cardiovascular Diseases, Frank M. Ryburn Jr., Chair in Heart Research, and the Director of Harry S. Moss Heart Center at University of Texas Southwestern Medical Center. Dr. Hill obtained his MD PhD from Duke University. Next, he got his postdoc training at the Institut Pasteur in Paris. Following that, he got his clinical training in internal medicine and cardiology at the Brigham and Women's Hospital, Harvard Medical School. Then Dr. Hill served as a faculty member in the University of Iowa for 5 years, and in 2002, he moved to University of Texas Southwestern Medical Center to assume the role of Chief of Cardiology and Director of Harry S. Moss Heart Center. As a physician-scientist, Dr. Hill's research focuses on mechanisms of structure, functional, metabolic, and electrical remodeling in heart disease and their application as therapeutic interventions. Dr. Hill also maintains an active clinical practice focusing on general cardiology, heart failure, and hypertension. Dr. Hill serves as editor-in-chief of Circulation, which is the highest-ranking cardiovascular journal. In addition, he serves in many editorial boards, including Circulation Research, American Journal of Physiology, Heart and Circulatory Physiology, and American Journal of Cardiology. He also receives numerous recognition and awards, including election of the Association of American Professors. He recently served as a president of Association of University Cardiologists and chair of the Academic Council of American College of Cardiology. He received the 2018 Research Achievement Award from the International Society of Heart Research and the 2020 Lucien Award from McGill University. He also recently delivered a 2023 William Harvey Lecture at the European Society of Cardiology. And he also received the 2023 Medal of Merit from the International Academy of Cardiovascular Sciences. So without further ado, thank you, Dr. Hill, for joining our webcast, and looking forward to your insight in the heart diseases. Thank you.
Well, thank you very much. It's for that very generous introduction, and it's my pleasure and honor to participate in this exciting webcast here. I'm sorry we had a little technical challenges with Zoom for a second there, but what I would like to do is tell you several inflammatory tales about inflammation, because what I would like to be speaking to largely are early career people and urging you to think about where cardiovascular science and medicine are going, not where they are now, because where they are now is not where they will be 10, 20, 30, 50 years from now. And I believe that inflammation has emerged now as an important and exciting mechanism and therapeutic target in multiple cardiovascular diseases. And I will try to summarize that here today. Inflammation has been a theoretical concept in multiple cardiovascular diseases for decades, including an atherogenesis, which all of you are aware is a process that requires decades to develop it. First of all, with the development of lipid-laden plaque in the wall of certain vascular beds, and something that takes decades to develop. And then last, at the end of the process, in a process that requires just weeks or days, there is an evolution of plaque rupture, plaque erosion, which can lead to an acute coronary syndrome. The first place where inflammation pivoted from a theoretical concept to a bona fide mechanism with therapeutic implications was in this space here, in the plaque rupture reality. Here in the famous trial CANTOS that was published now 7 years ago, where a surgical strike on a single pathway, the interleukin-1 beta pathway, with this compound here, canakinumab, led for the very first time to mortality benefit in cardiovascular diseases. That was a thunderclap across the field. Suddenly inflammation emerged as a bona fide mechanism and target. The field then pivoted to the more chronic phase of atherogenesis, where after studying patients in CANTOS who had a recent ACS and had elevated CRP indicating residual inflammation, the next step, which is typical, is to notch it down to subjects that are one notch less ill. Here in the Colcott trial, using the centuries-old medicine colchicine. And again, here we are just 2 years later, another trial demonstrating mortality benefit in atherogenesis. This was followed by another trial, Lodoco-2, with patients who are yet more stable, one notch more stable. And again, colchicine demonstrated mortality benefit here in another paper just 1 year later. This pathway, with which you're all familiar, which I've illustrated here, starts with the NLRP3 inflammasome, IL-18, IL-1 beta, IL-6, culminates in this pathway, this single pathway of inflammation. On the right, we've illustrated compounds that have been shown to confer benefit. I've already mentioned canakinumab and colchicine. On the left are other compounds targeting this same pathway at different points that are currently being investigated. So there's one inflammatory tail. Now, targeting inflammation globally does not necessarily confer benefit. For example, methotrexate, which you can sort of think of as dialing down the global inflammatory response, does not confer benefit. Inflammatory tail number one. Here's number two, clonal hematopoiesis of indeterminate potential. You're all familiar with this, a process where all of us have circulating hematopoietic stem cells that are constantly dividing, and every once in a while a mutation will emerge that confers a growth advantage on one clone relative to the other. And that clone will then begin to populate the hematopoietic stem cell population such that by the time we're 70 years old, 10% of us have this so-called CHIP, clonal hematopoiesis of indeterminate potential, that being defined as a 2% abundance of that clone. It's said to be indeterminate potential because typically it does not emerge as a lymphoma or a leukemia, but rather what it does do is confer risk of atherothrombosis. Number two, our second tail. Mechanisms are currently being explored. This is a very exciting area. Neutrophil extracellular traps appears to be one of the mechanisms that links CHIP to atherogenesis. Epigenetic mechanisms appear to be another. So there's two more inflammatory tails. Here's a fourth, the so-called cGAS STING pathway. You're all familiar with the fact that double-stranded DNA is supposed to be packed away in your nucleus or in mitochondria. It is not supposed to be in the cytosol. In fact, we have evolved to interpret double-stranded DNA in the cytoplasm as evidence of infection with a double-stranded DNA virus. And that elicits an inflammatory response to kill that cell, lest that virus infect other cells. The way in which this occurs is a molecule called cGAS, which recognizes double-stranded DNA in the cytosol, triggers a cascade of events that I won't go through in detail, a second messenger called cGAMP that activates a molecule called STING. This pathway is called cGAS STING, which ultimately culminates in a type 1 interferon response. This CHIP pathway was shown a couple of years ago to activate the CHIP that I'd mentioned before, to activate C-gas sting. So there's a third way in which CHIP activates an inflammatory response, contributing to atherogenesis and perhaps other forms of cardiovascular disease. We, in fact, have worked on C-gas sting over the years and are continuing to do so, recognizing, as I said, that DNA is a signal to activate the immune response. And the notion occurred to us that when you rupture a plaque leading to necrosis of the myocardium, you are lysing millions of cardiac myocytes. And I'll remind you that I believe cardiac myocytes probably harbor more DNA than any other cell type. 40% of the biomass of a cardiac myocyte are mitochondria full of DNA. Imagine if you ruptured millions of those, there would be double-stranded DNA flying all around the myocardium. By way of background, of course, we did not evolve to deal with myocardial infarction, but here's what happens when that occurs. Initially, over the first several days, there is an invasion of inflammatory monocytes to clean up the necrotic tissue. A few days later, a second wave of reparative monocytes that rebuild the tissue emerge. 3 or 4 days of tissue cleanup followed by a phase of tissue repair. We hypothesized a few years ago that cytosolic DNA, again, there's cytosolic DNA flying around the necrotic myocardium in the setting of an acute coronary event, that perhaps this governs that macrophage response, that phenotypic switch between the cleanup macrophages and the rebuilding macrophages. That was a hypothesis. To test that hypothesis, we asked first, is this pathway activated in the setting of myocardial infarction? When double-stranded DNA binds C-gas, I'll remind you that there's this cascade that I have not shown here, but the business end of this cascade are so-called interferon stimulatory genes listed here. So we asked the question, are those genes activated in the setting of experimental myocardial infarction? In fact, we found that each one of them, all 4 of them here, in the infarct zone of tissue are activated at day 3 and day 7. You can see in each case. They are not activated in the uninjured remote zone. And if we silence the gene coding for C-gas, that activation of this pathway is not present. So we discovered that, in fact, this C-gas sting pathway is activated in myocardial infarction, and it is C-gas dependent. So then the next question is, our hypothesis is the phenotypic switch between the M1-like macrophages and the M2-like macrophages, the tissue cleanup and the tissue rebuilding phases. Perhaps this phenotypic switch is governed by C-gas, such that if we silence the gene for C-gas, perhaps we could bring in the healing macrophages a day or 2 earlier, A, and B, perhaps that would be beneficial. If we compare wild type and C-gas knockout mice, you can see that the abundance of these M2-like macrophages is increased at day 3 in the C-gas null mice, and at day 6 that is still present. So we are, in fact, bringing in those healing macrophages a little bit earlier. The matrix, the myofibrillar matrix, appears to be more robust. The rebuilding appears to be accelerated at day 6. There's an angiogenic response. And if we compare tissue integrity here in 3 different ways, trichrome, picoseries red, and polarized light, with an inset in each case over here, you can see that if we compare this inset to this one, you can see that the tissue appears to be more robust at 1 week. The tissue appears to be remodeled and strengthened relative to wild type. The decline in contractile performance that we typically see is in fact blunted when we knock out C-gas. Often mice in the setting of MI develop a rupture phenotype with mortality around 50% in our hands at 1 week, and that is largely abrogated as illustrated here. So the next question is, does this pathway have any relevance to human beings? If we take heart failure samples from individuals with ischemic heart disease, you can see that sting, the abundance of sting is robustly increased relative to normal LV, and at least in an associative experiment where we compare tissue that is being supported with a left ventricular assist device, the abundance of this pathway appears to be mitigated in the setting of mechanical circulatory support. And the final point I'll make about this inflammatory tail is, in fact, there are drugs approved for human use that target this CGAS sting pathway. So the postdoc who did this work, Diane Cow, has launched her lab, and she's tenured with associate professor at this point, and she and I are collaborating on new questions around this pathway. So again, let me remind the early career people in the audience, I urge you to skate to where the puck is going to be, because it's going to be in a different place 20 years from now, 30 years from now than where it is today. And I believe much of that future will be governed by the cardiometabolic stress of obesity, the global pandemic of obesity that we're seeing around the world, high-income countries, low and middle-income countries globally. And where obesity lives is where type 2 diabetes lives. We're seeing an explosion of type 2 diabetes around the world. If you take 500,000 people with type 2 diabetes, fully 27% of them have heart failure. What kind of, again, heart failure, I submit to you, will define much of the future of cardiovascular medicine and science. What kind of heart failure do these individuals have? Heart failure with a preserved ejection fraction. You're aware that for our patients with heart failure and reduced ejection fraction, our armamentarium is replete with many powerful agents, including several that are relatively new: angiotensin receptor neprilysin inhibitors, SGLT2 inhibitors, cardiac resynchronization therapy, mechanical circulatory support. Down the road, maybe vericiguat, maybe omecamtiv mecarbil. There are many things that we can do for our patients with HFrEF. For HFpEF, we've got nothing. Nothing, with the possible exception of SGLT2 inhibitors. And if there's time at the end, I'll be pleased to discuss that further. We have nothing, or at least very little. It's been said that HFpEF is the single greatest unmet need in cardiovascular medicine. Now, why is that? It's not for want of trying. People have been studying HFpEF for decades, and nothing has succeeded. There's a graveyard of failed clinical trials in this space. And my personal belief is one of the major reasons underlying that is that clinical providers who understand exactly what HFpEF looks like clinically are often not trained to glean underlying molecular mechanisms. Conversely, brilliant PhDs who are professionals at working out mechanisms often don't know the clinical realities. There has been a failure of communication between these two professional groups. And I believe that that has contributed importantly to the numerous dead ends that we've seen in this space. Now, to address this, I was fortunate to recruit a cardiologist from Italy several years ago who wanted to do a PhD in our group. And he and I sat in this room here and discussed the fact that we have nothing to do for our HFpEF patients, and HFpEF is now more prevalent than HFrEF. In fact, it's going up every year, and it's already exceeding the prevalence of HFrEF. We have nothing to do for those patients. And number two, the preclinical literature is polluted with many different studies that simply do not reflect the realities we see in our patients. So I'm going to tell a long story in a telescoped way here. Gabriele and I decided to test a simplified, simplistic idea that we would simply make a mouse that looks like a patient with HFpEF. HFpEF is not a genetic disorder. It is a lifestyle disorder. Most patients with HFpEF are obese with metabolic syndrome or diabetes. Most of them are hypertensive. So we simply made a mouse that was obese with metabolic syndrome and hypertensive, a so-called two-hit hypothesis, where we simply tried to make mice that look like human beings with HFpEF. And a long story short, we're over the next several years, we concluded that this pathway, the culmination of mechanical stress and metabolic stress, leads to a syndrome of HFpEF. And I'm pleased to say that this model, this two-hit model now, has exploded around the world in academia and industry. It is replicated, and I believe is helping restart this field. We worked out this pathway that had previously never been described in cardiovascular medicine, a pathway of so-called meta-inflammation, metabolism-related inflammation, as illustrated here. We worked this out in our two-hit mice, in ZSF1 obese rats, and in human beings with HFpEF. In subsequent work, we worked out the question, how is it that XBP1S, this deficit of XBP1S, how is it serving as a brake on HFpEF? I don't have time to show you the data, but basically it promotes the expression of an E3 ubiquitin ligase that targets this bad actor called FOXO1 for degradation. When it is not degraded, FOXO1 wreaks mischief on the myocardium, which we are working actively to try to understand. Now, I'll remind you that the myocardium is an omnivore. It has to consume substrate 24/7. Its preferred substrate is fatty acids. It can also consume ketones, amino acids, glucose. It has to eat all the time. Now, in the setting of mechanical stress, like hypertension, it will tend to use more glucose. We've known that for a long time. However, in the setting of metabolic stress and insulin resistance, it can't. It can't use more glucose. So these poor hearts are being pulled in two different directions, asked to do something that they cannot do. And in fact, if you look at their mitochondria, you can see at the structural and ultrastructural level, they are perturbed. And again, I don't have time to show you all the data, but this is a snapshot of a mitochondrion where we find that the TCA cycle is perfectly normal. The electron transport chain is normal, but we uncovered two defects, one at the level of pyruvate intake into the TCA cycle at the level of PDH, pyruvate dehydrogenase, and number two enzymes in the beta oxidation pathway that are hyperacetylated and crippled. They're hyperacetylated in association with the fact that the deacetylase that normally would cut that acetyl group off, SIRT3, is downregulated, and its required cofactor NAD is similarly downregulated. So in this story, in our two-hit model, we find that we develop HFpEF, and there is a deficit in NAD, as I mentioned, a hyperacetylation response, and diminished mitochondrial function, such that if we restore NAD levels, either pharmacologically or by promoting its biosynthesis, NAD levels go up, that hyperacetylation response is aborted and mitochondrial function improves. So now we have a first-in-human clinical trial here going on at UT Southwestern testing NAD repletion in patients with HFpEF. So with that, I will stop. I'll remind you that cardiovascular diseases are the #1 killer of men and women around the world, and they are evolving. They're very different today than they were 20, 30 years ago. They will be different again in the future. Clinical providers will continue to take care of this ever-expanding issue of cardiovascular diseases, but yet the ultimate solution is at the level of research, where we begin to understand mechanisms that lead to these disorders. This is my group in a picture that's a little bit old. Tom Gillette is a partner of mine and the lab now for many years. Amanda Tong now has her own lab. She's the one who did the mitochondrial work. She also did a sexual dimorphism study and an atrial fibrillation study. And Diane Cow is not shown here. So with that, I will stop and welcome visitors here to Dallas anytime. It's been my pleasure to share some of these results with you. And if there's time, I'd be pleased to field questions. Thank you for your attention.
Thank you so much, Joe. You are truly the Wayne Gretzky of cardiovascular medicine, skating to where the puck is going to be. And really wonderful talk. I appreciate that. I really enjoyed it. Thank you for that.
Thank you.
I do have a couple of questions for you. I'll start with one, and then Lily, you might have some as well. We're both very interested in the work you've done, both the clinical work and the preclinical work that you've done, and want to hear more about it. I have a question about the anti-inflammatory strategy. for cardiovascular disease. You told us about the CANTOS study and the Lidoco, the colchicine studies, and showed us that those did reduce major adverse cardiovascular events, whereas methotrexate did not. And I'd like to maybe understand from you what the mechanisms are. Do you think it's different pathways that are being affected by those different anti-inflammatory drugs that resulted in the different consequences of the trials, the different different effects? Or do you think it's perhaps was it due to different levels of inflammatory inhibition?
Well, yeah, thank you, John. You know, this is one of those phases of my life, in my professional life, where I have to learn a whole new field, and I'm not an immunologist, but I'm working on it. And so, you know, I don't know the answer. I don't think anybody knows the answer, but as you're aware, in the 1970s, people used to treat MIs with steroids, glucocorticoids, right? And the results were disastrous. So you can dial the immune system way down and not confer benefit. So my hypothesis is that a surgical strike on specific pathways, like the IL-1 beta pathway, the CGAS sting pathway, that rather than try to dial down the entire system, rather we have to have a more detailed understanding of the pathways and what they're doing. And I told you 5 different tales where those individual pathways, I think, are emerging with promise. But my read of the literature is just turning it all down, turning the volume down globally is not an appropriate strategy.
That makes a lot of sense to me, and I'm sure there's multiple reasons that for you being right on that score. One thing that we've done is we found that some amount of inflammation, and no surprise, is absolutely critical for healing. And you pointed out that steroids can actually have adverse effects after myocardial infarction. We've found that inflammatory signaling is absolutely critical for cell fate transitions. And without inflammatory signaling, it's unlikely you can get the increased DNA accessibility that you need for a cell fate transition. That inflammatory signaling can be positive or it could be negative. You can have inflammatory signaling that prompts a pathologic cell transition, or you can have inflammatory signaling that prompts a physiological reparative cell transition. And it depends upon the milieu at the time. So I do agree with you that having a more surgical strike on the inflammatory signaling pathways and knowing, what pathways you want to knock down, what pathways you may want to facilitate, is going to be important for us to keep moving forward to skate where the puck is going to be. Lily.
Yes, Dr. Hill, thank you so much for your talk. I really appreciate it. And before I go into any scientific question, I'm very curious about how you can balance your basic science research and your clinical practice. I think to me it's very stunning. You can do both and do both very well. So.
Well, you're nice to say that. They say, the expression that if you love what you do, you never go to work, right? Work is never work. And, I decided to be a physician scientist a long time ago, and I firmly believe I'm a better scientist because I'm a doctor, and I'm a better doctor because I'm a scientist. I really believe that. I see patients with HFpEF all the time, and then I walk back to the lab in the afternoon and we study HFpEF. And the way I've done my science for all these years, and I continue to do it, is starting with a disease. So the disease that people get and then drilling down wherever the mechanisms take me. Right now, it's taking me into inflammation, and I'm trying to become a wannabe immunologist. So, as a leader, running a lab is being a leader. Being a doctor is being a leader. Being a chief of cardiology is being a leader. Editing a journal is being a leader. And I believe that leadership skills are not innate. There's no gene for leadership. It is a learned skill. And my personal style around that right or wrong, is one where I'm very comfortable with a horizontal leadership strategy. In circulation, we have 50 associate editors, and every single one of them is a leader. They make, ultimately I'm responsible and have to make the final call, but at this point, I've been doing this for 8 years, and I think we've handled something like 40,000 papers. And I can tell you that I moved the needle a little bit this way or that way, probably a dozen times out of 40,000. Most of the time, we have a robust discussion and we arrive at a consensus. And that strategy where you enable people to become leaders and have ownership of what they do is an incredibly powerful strategy that has worked well for me. And honestly, the way it works at circulation, now that I'm on it, is every paper is read by 5 different sets of eyeballs, and often it's a dozen people read them. And we have a conversation every week, and we almost always, 99.9% of the time, achieve a consensus, often a unanimous consensus. Occasionally there's one person who disagrees and we move on. But that horizontal leadership where you deputize other people to be leaders in your arena enables you to do a lot more in your professional life.
Thank you so much for your insights. And so then I want to have my scientific questions. So I noticed in your C-gas knockout mice, it's a general knockout, right? So I noticed you are focusing on the macrophage functions. Do you ever try to study any other cells that potentially modulated by this pathway as well?
That's a great question. So what I did when Diane, that postdoc, I handed that project to her and backed away so that she could launch her career, and she's doing great. Now, in the last year or so, she and I have partnered. We wrote a grant together, and we partnered to address the role of T cells in pressure overload heart disease. And so she is focusing on C-gas in dendritic cells, and I'm focusing on C-gas in T cells. And we're partnering together to ask those very same questions. Right now, we're focusing primarily on T cell biology.
Okay, so I think the reason why I asked this question is because I noticed that in your C-gas knockout mice, there is increased alpha SMA production and also the CD31 positive endothelial cells. So actually, in our we are interested in the phenomenon of a phenomenon called transdifferentiation, which the fibroblast cells can be turned into endothelial cells, and we focus this phenotype in the high limb, and we also find a very similar phenomenon which we can see over the activation of fibroblast cells as well as a transition from fibroblast cells to endothelial cells. So that's why I see, because you have this general knockout mice, I probably will also think if there is such a transdifferentiation phenomenon happen in your condition as well. So.
Well, you guys are the expert on that, and I'm very familiar with your work. We are not working on that right now. My guess is that there's C-gas sting in many different cell types. Whether in the setting of an acute coronary event, their DNA, double-stranded DNA, penetrates endothelial cells, I don't know. We looked on macrophages first because they're the ones who are doing that. But we do have evidence that the pathway is activated in T cells, and so this pathway, again, which another group has shown is at the business end of CHIP as well, I think it's going to be an exciting area that has been shown already to have mechanistic implications in cardiovascular disease.
Joe, you mentioned that you're becoming an immunologist, and you mentioned T cells is something that you're starting to look into. There was this, and also speaking of skating to where the puck's going to be, I thought it was really interesting what John Epstein did, his paper in Science, I think about a year and a half ago or so, where he generated CAR T cells against cardiac fibrosis. I don't know if you saw that one, but he took T cells and used an mRNA construct to generate a CAR T cell against activated myofibroblasts, and had some positive results in his animal model. What do you think about that approach, using T cells generally for modifying CAR T cells for cardiovascular conditions?
Yeah, I'm very familiar with his work, and he's taking that in new directions. He's formed a company and everything, which is exciting to pursue that. He had a more recent paper where he envisioned generating those T cells. I think in that first paper he injected the T cells, and now engineering the myocardium so that, or the organism, such that they can make their CAR T cells endogenously. Yeah, I think that's an exciting area, and I fully recognize that under certain circumstances, targeting fibrosis is beneficial. I personally worry about that. I was just at a meeting where I heard several talks about targeting cardiac fibrosis as if it were, the bogeyman of all bad things and HFpEF and everything else. And that's a tricky one because, like I mentioned, if you target fibrosis in MI with steroids, you get a rupture phenotype, right? Mm. So, fibrosis comes in two flavors. Sometimes you need it to restore, like in the CGAS experiments, you need it to restore the integrity of the mechanically active myocardial tissue. Later on, it does bad things, as we know. So I wonder how people who focus on this, and I'm not really one of them, how you can envision making sure you target bad fibrosis and make sure that good fibrosis is retained. And I know John's work has so far been very effective, and so maybe he's onto a strategy to do that. But targeting fibrosis is, I would voice a word of caution about targeting fibrosis, either pharmacologically or by altering, genes that lead to fibrosis, because it's not always something you want to get rid of.
Your work with CGAS is really exciting. Are you thinking of, potentially developing an antagonist against CGAS, or a monoclonal antibody directed against CGAS, or a vaccine? Would those be potentially useful therapies for HFpEF?
Potentially. We haven't gotten that far in that process, I will say. I'm sure you all know that this CGAS sting pathway is one of the hottest things in biology. You can't pick up an issue of Science or Nature and there's not CGAS sting something. We're working on the myocardium, but it's involved in many, many, many different things. And so it is a super hot area of science. And as a result of that, we benefit from reagents that other groups are developing, in other areas. Right now we're focusing on, is it active, and if so, what does it do, and how does it do it? But of course, ultimately, our vision is a translational element to target it if we find that is appropriate down the road.
Mm-hmm. If you did, what would be your concerns? You mentioned about the concerns about targeting fibrosis. What about targeting the CGAS sting pathway? Are there potential liabilities to doing that?
Well, it's a great question. When we developed the CGAS knockout mice, their immune system is suppressed, and I thought these poor mice are not going to do well. And you know what? They're perfectly normal. Huh. Even though their immune system is crippled, at least to some extent, mm-hmm. we find no evidence that it has an impact. So, if you go targeting it globally with a pharmacological strategy, it's going to have immune responses, ways in which you deal with pathogens all day long. And so there's some reason to think hard about that.
We do have some questions from the audience. Do you want to read this one?
The question for audience is, considering that many anti-inflammatory drugs have faced challenges in the therapy of heart failure with HFrEF, the audience is interested in understanding their potential efficacy in heart failure with HFpEF. have there any promising developments or insights regarding the use of anti-inflammatory drugs in HFpEF, and what factors contribute to their success or challenge in this specific context?
Well, that's an interesting question. You're absolutely right. I mean, the anti-TNF therapies in HFrEF were, a terrible failure. Again, the TNF pathway is a big one. So, but as I mentioned, we've uncovered this pathway called meta-inflammation in HFpEF, and it clearly is a driver. And so we and others around the world are trying to target that pathway using a variety of strategies. One of the major endpoints of meta-inflammation is a dramatic upregulation of iNOS, a 7 or 8-fold increase in iNOS. I'll remind you that iNOS generates 1,000 times more NO than does eNOS. So these organisms are flooded with NO, which covalently links to many, many different proteins. And we worked on a few of those. Now, there are drugs or there is at least one drug approved for human use that targets iNOS specifically. And we've thought about it for several years now. I have to tell you that my thinking, right or wrong, is in order to do that, to jump from mice to men is a stretch. So we've tried now for quite some years to develop a non-human primate model of HFpEF, working with collaborators in China. And I will tell you that a bit of a funny story that monkeys will not consume L-name. They simply will not consume L-name. We've tried it in many, many, many different strategies. They won't. And then as we were continuing to work on it, the COVID pandemic hit, and the price of monkeys in China increased tenfold, 10x. So it became financially crippling, at least at the present time. We haven't given up, but in fact, I have a call this afternoon to talk about it some more with another strategy with places that have large cohorts of monkeys that are aging. And our hypothesis is that, some of these monkeys get obese and hypertensive just like people, and maybe some of them have HFpEF. So we're still working on that. That's the strategy we're taking in that regard.
Interesting.
So I have another question. So since you're talking about the cytosolic DNA as the alarm for the stress, so also I'm assuming this cytosolic DNA are from mitochondria, right? So what is the mechanism that releases this mitochondrial DNA into the cytoplasm?
Well, that's a good question. We've never people have asked me that. We've never tried to figure out where the DNA is coming from. Probably most of it is mitochondrial, as you say. But when a myocyte is lysed and all of its contents are released, those mitochondria are subject to degradation and proteolytic attack and so forth. And so that is our thinking. We've never actually sought to try to prove that. Where's the DNA coming from and where, what source? But this concept of robust activation of the C-gesting pathway we've seen now many, many times is very, very reproducible.
Okay, so we have another question that is, you're talking about the C-gas pathway in the mitochondria, but is it affecting the residential macrophage, or is it from the differentiated mitochondria from the peripheral circulation? Do you have different role in this different mitochondria?
Different mitochondria?
Yeah, I think the different source. So one is residential, one is differentiated. I think these two type of mitochondria may have different functions, or do you think?
Oh, I see. Yeah, that's great. Yeah, we haven't worked on that. I thought you were meaning the macrophages that are migrating into the myocardium. It appears to be those, but that's a different question. But we've not tried to parse the different types of mitochondria inside the myocyte, if that's your question.
Yes.
Your story on hyperacetylation, it was interesting to me because you were focusing on how that impaired NAD generation. And now you have a trial going on with NAD repletion in HFpEF. So that's quite interesting. What effects on the epigenetics of the heart do you think occurs with that metabolic abnormality, the hyperacetylation? Do you think there's hyperacetylation going on in the chromatin?
I'm going to say we haven't looked at that, honestly. We have not looked at that. One of the puzzles that we ponder is these abnormalities, this meta-inflammation that we see, the ER stress response is altered. I didn't have time to show you all that, but that is coupled with this profound mitochondrial disorder. How do those two things communicate? What is the connection between the perturbed ER stress response, this huge increase in circulating NO, and what's going on in the mitochondria? We haven't figured that out yet. There must be. I doubt that they're two independent events. There probably is some link, but we haven't discovered that.
Well, this was great, Joe. We have a time for some final comments from you. Anything more that you'd like to share with the audience before we close? Career advice or scientific advice, new insights? Well, I love to speak to audiences like this, and especially focusing on early career investigators. I will tell you that heart disease is evolving in front of our eyes. Many people don't recognize that 1 in 4 women will die of heart disease, 1 in 4. Contrast that with breast cancer, which is 1 in 40. A woman is 10 times more likely to die of heart disease than breast cancer. And the field is evolving rapidly. The challenges today are different than they used to be. That said, the tools at our disposal are incredible. CRISPR-Cas9, different therapeutic strategies, clinical strategies with pharmacological approaches, iPS cells, all the things that you folks know about. The tools at our disposal are absolutely robust. The challenges are evolving, but we are armed with incredible tools, and there's never been a more exciting time, in my view, to be in cardiovascular science. Thanks, Dr. Hill, for your enthusiasm and your insights and your wisdom. It's been great spending some time with you today. Thanks for joining us at the cutting edge of cardiovascular sciences. Thank you very much.